Vanakkam. When we say brachydactyly, we understand that it is brachy or short and dactyly or finger. So it's a short finger. And if the finger is short, obviously the bones inside are shorter or smaller. But which of the bones is shorter? And how do we classify brachydactyly? Why is brachydactyly caused? And if it is a shorter bone in the finger, obviously the treatment is to lengthen the bone. Is that all? Or is there any other procedure that needs to be done? All this are discussed in this video on brachydactyly. In the last few videos, we have seen about syndactyly where fingers are joined, macrodactyly where the fingers are large, camptodactyly where the fingers are bent in the forward direction, and clinodactyly where the fingers are bent in the lateral direction. In this video, we shall see the details about brachydactyly. Brachydactyly is derived from Greek, where brachy refers to small or short and dactyly of course refers to the finger or digit. We have seen that the Swanson's classification for congenital differences of the upper limb include 7 categories. Brachydactyly has been classified under the 5th category, which stands for undergrowth. Since brachydactyly refers to short finger, it is obvious that there is a shortening of the bones. So we could easily classify brachydactyly as brachytelephalangy or shortening of the terminal phalanx, brachymesophalangy where there is shortening of the middle phalanx, brachybasophalangy shortening of the proximal phalanx, or brachymetacarpia where there is shortening of the metacarpal. But that is if we tend to assume that this type of congenital malformation is straightforward underdevelopment. On the contrary, brachydactyly might be the most complicated group of congenital anomalies of the hand. If it involves the whole hand evenly or the entire structure of its components, it would be quite straightforward. But undergrowth is often affecting only some structures of a digital unit, and sometimes the undergrowth is associated with other groups of congenital deformities such as failure to differentiate or failure to form. So obviously this classification is not enough. In 1951, Bell attempted to classify brachydactyly by distinguishing 5 main types A through E, and in 1978 Temteme and McKusick expanded this classification. Let us see these different types and what they stand for. Type A is characterized by shortened middle phalanges alone. Depending on the affected digit, it could be subdivided into 5 subtypes A1 to A5. Type A1 is sometimes known as the Farabi type brachydactyly, where there is shortened or underdeveloped middle phalanx in all the digits as well as the proximal phalanx of thumb. But the second and fifth fingers are most frequently affected. The X-ray of an adult's hands with brachydactyly type 1 showing brachymesophalangia of 4 digits or shortening of the middle phalanx of 4 digits with hypoplasia of the thumb's proximal phalanx. Type A1 brachydactyly is inherited in an autosomal dominant pattern, and it is caused by mutations in the gene IHH or the Indian hedgehog located on chromosome 2. Type A2 brachydactyly is referred to as the more rate type brachydactyly, where there is absent or shortened middle phalanx of the index finger, which may be associated with shortening of the middle phalanx of the little finger. X-ray showing absence or shortening of the middle phalanx presenting with a distinctive triangular shape. This type of brachydactyly is also inherited in an autosomal dominant pattern and is caused by mutations in the BMPR1B gene located on chromosome 4. Type A3 brachydactyly is known as the Bohr brachydactyly. It consists of a shortened middle phalanx of the little finger, and this is the more relatively common brachydactyly and frequently associated to other morphological anomalies. the small middle phalanx of the little finger is seen, but the criteria is that the middle phalanx of the little finger must be smaller than half the middle phalanx of the ring finger. Also inherited in an autosomal dominant pattern, but no causative mutation has been identified so far. Type A4 brachydactyly refers to Temtami type brachydactyly, where there is a shortened middle phalanx of the index and little fingers with bifid appearance of distal phalanx of thumb, which is seen as nail dysplasia. In these patients, mutations in gene HOXD13 have been reported in affected family members. Type 5 brachydactyly is known as Bass type brachydactyly. Here there is absent middle phalanges of index to little fingers associated with nail dysplasias. We have seen type A brachydactyly. Type B brachydactyly is known as Mackinder's brachydactyly. Here there is absence or hypoplasia of the distal and middle phalanges. They present with absent nails on the second and fifth digit, while the distal phalanges of the thumb are malformed. Other anomalies may be associated, such as syndactyly, symphalangism, carpal fusion, and also shortened metacarpals or metatarsal bones in the toes. X-ray of a 2-year-old child showing brachydactyly type B. Here there is agenesis of the distal phalanges and hypoplastic middle phalanx of the second, fourth and fifth digit, hypoplasia on the right side and agenesis on the left side of the distal phalanx of the middle finger and bifid distal phalanx of the thumbs. The transmission of type B brachydactyly is autosomal dominant and is caused by mutations in ROR2 gene located on chromosome 9. Type C brachydactyly is known as Drinkwater's brachydactyly. Here there is brachymesophalangy of the middle phalanx of the second, third and fifth digit. It may be associated with hyperphalangy, that is more than 3 phalanges of the index and middle fingers, as well as shortened first metacarpal. Usually the ring finger is not affected, so it is the longest finger in this type of hand. The proximal phalanx of the index finger may have an ulnar deviation. A representative X-ray of this type of brachydactyly showing shortened middle phalanges of the second, third and fifth digits, shortening of the proximal phalanx with ulnar deviation of the index finger and shortened metacarpal of the thumb. This type of brachydactyly is also inherited in an autosomal dominant manner caused by mutation in gene CDMP1. Type D brachydactyly is known as Breiten-Becker's brachydactyly. Here only the distal phalanx of the thumb is shortened, and this shortening occurs in varying degrees, may affect one thumb, both thumbs and even the big toe. The base of the distal phalanx is often broader than the surface of the proximal phalanx to which it articulates. This has an autosomal dominant inheritance pattern, but no causative mutation has been identified so far. Type E brachydactyly is known as Bell's brachydactyly, characterized by more or less marked shortening of the metacarpals with possibly abnormal size of phalanges. This type of brachydactyly may be an isolated condition or part of a malformation syndrome like Turner's syndrome. X-ray of a 11-year-old boy's hands showing brachymetacarpia or shortening of the metacarpals of the middle, ring and little finger digits. This also has an autosomal dominant inheritance pattern and no causative mutation has been identified. We must differentiate congenital brachydactyly from other causes of short digits like pseudo-hypoparathyroidism, pseudo-hypoparathyroidism and acrodysaustosis. There are many syndromes associated with congenital brachydactyly. We shall consider 3 of the most commonly occurring syndromes. We need to look for these syndromes when encountering a patient with congenital short fingers. Robinow syndrome is a rare syndrome characterized by digital and skeletal anomalies like mesomelic shortening of the limbs, rib fusion, hemivertebra and scoliosis, distinctive facial dysmorphism like hypertelorism, midfacial hypoplasia and nose anomalies, genital hypoplasia and small height. Brachydactyly in these patients is characterized by shortening of the distal phalanges, nail dysplasia and clinodactyly of the little finger. Rubinstein-Tybee syndrome is characterized by mental and growth retardation, microcephaly, facial dysmorphism which includes downward and outward slanting palpebral fissures, ptosis and anomalies of the extremities. Also may be seen high arched palate and characteristic broad nasal bridge. The hands in such patients are short and broad with short thumbs where the distal phalanx is broad and often pointing outwards. Turner syndrome is a chromosomal disorder in which an X chromosome is absent. So the karyotype is 45X0. Clinical features are heterogeneous skeletal malformations associated with short stature, ovarian failure, deafness as well as cardiovascular, thyroid, digestive and cutaneous anomalies. The bony malformations often consist of brachymetacarpia or brachymetatarsia, mainly affecting ring finger. The epidemiology of occurrence of brachydactyly is quite diverse. It is typically an inherited condition with an autosomal dominant pattern of inheritance. It may also occur as a sporadic anomaly. It may be part of a systemic syndrome. It can also be seen as a non-congenital brachydactyly which occurs after growth plate injury as a result of trauma or infection. There are two very important points that must be considered when discussing about congenital brachydactyly. The first is antenatal diagnosis. Prenatal diagnosis is usually not indicated for isolated forms of brachydactyly, but it may be appropriate in syndromic forms. Short phalanges may not be clearly evident by fetal ultrasonography early in development and will only be visible later on if expressed. Molecular studies of chorionic villus sampling at 11 weeks of gestation and by amniocentesis after the 14th week of gestation can provide antenatal diagnosis if the causative mutation is known to run in the family. The second important point to be considered is genetic counseling. The nature of genetic counseling depends both on the pattern of inheritance of the type of brachydactyly present in the family and on the presence or absence of accompanying symptoms. If the brachydactyly follows an autosomal dominant pattern of inheritance, the chance of recurrence in the offspring of affected individuals is 50% regardless of sex. If there is an autosomal recessive pattern of inheritance, which is seen in very rare congenital brachydactyly, the risk of recurrence in the sibling of an affected case is 25%. As far as the clinical presentation is concerned, the severity of the digital shortening is variable. Mild shortening may sometimes be apparent only because the normal cascade of the digits is disrupted. The index and little fingers are the most commonly affected digits and the middle phalanx of the fingers is the most commonly affected bone. Associated anomalies such as syndactyly, clinodactyly and symphalangism also exist, and when they do, the functional problem is more. Apart from examining the affected hand, we also need to examine the remainder of the upper limb, the pectoral girdle, the contralateral upper limb and the lower limbs. Also, additional limb or chest wall involvement needs to be examined because it may lead to the diagnosis of a specific form of brachydactyly or a more inclusive anomaly like Poland syndrome. We also need to examine the parents and siblings, which may reveal further evidence of an inherited anomaly. Traumatic brachydactyly is usually identified by a history of injury and subsequent radiographs that reveal physeal arrest. Regarding the management of brachydactyly, we need to consider two problems that occur due to the condition: the loss of function and the cosmetic problem. After considering the problem that is there in the patient, we need to consider three important criteria: the degree of shortening that has occurred, associated anomalies, and the status of the remaining digits. In a complex anomaly, brachydactyly may be a relatively minor component in comparison to the associated problem like syndactyly, clinodactyly, or symphalangism. As an isolated deformity, the indications for intervention are either aesthetic or functional. The appearance of the hand is most affected when the normal cascade of the hand is disrupted, particularly the central digits. A short central metacarpal head may be palpable in the palm and may interfere with power grip also. In considering surgery for such patients, there may be enthusiasm on the part of the parents, the patient sometimes, but potential problems associated with lengthening such digits must be explained, including joint stiffness, contracture, and the loss of hand function. Before considering the techniques of lengthening procedures for shortened digits, we shall first discuss the principles of management of commonly occurring brachydactyly patterns, that is, brachymesophalangy, shortened middle phalanges; brachymetacarpia, where shortened metacarpals are seen; clinodactyly occurring with brachydactyly; and symbrachydactyly. Since the middle phalanx is the most commonly affected bone in brachydactyly, we shall consider brachymesophalangy first. Simple shortening of the middle phalanges does not give rise to functional disturbances. However, there may be two situations where surgical correction has to be considered. The first is when shortening of the digit is producing a lateral decline of the digit, that is associated with clinodactyly, and secondly, when the distal phalanx is also affected, giving an expanded, unattractive distal end of the finger or thumb with a broad nail. The presence of short metacarpals per se does not give rise to functional impairment also. In some cases, however, when the shortening occurs in the central digits, the disfigurement becomes striking and parents and the child may want correction. If the shortening is mild, elongation may be achieved by a block bone graft in a single operation, which will be discussed later in this video. Elongation for more major deficiency is achieved through bone transport using a distractor. When brachydactyly is associated with a delta phalanx, commonly occurring in the index finger which is free to bend radially, severe clinodactyly results. Apart from an abnormal appearance, functional pinch is also affected. When the shortening is not severe, correction of the clinodactyly is the priority, even at the expense of further sacrificing a slight amount of length. Surgical treatment of the delta phalanx is undertaken, and this has been discussed extensively in a previous video which you can access by clicking on the link above. In symbrachydactyly, there is a presence of webbed fingers or syndactyly which is associated. The fingers may be very hypoplastic sometimes. The procedures for syndactyly release in symbrachydactyly are the same as for simple syndactyly. But because the digits are short, the interdigital spaces should be made deeper than usual in order to gain more functional length. And in severe symbrachydactyly, rudimentary rays can be excised, especially if the thumb web is affected. The obvious surgical management of brachydactyly or shortened fingers is lengthening procedures. These procedures mostly use the dorsal approach to the phalanx or metacarpal that is short, and to achieve lengthening, two techniques can be used. The first technique is distraction lengthening, which is achieved in two steps. The first step being a simple transverse osteotomy of the short end bone, and application of a distraction frame for lengthening the involved bone, usually with two pins on either side for stability and alignment. The advantages of using this technique of distraction lengthening are that concomitant soft tissue lengthening also occurs, there is a limitation of contracture and stiffness, there is a regeneration of bone, so there is no need for a bone graft, and gains in length of up to 15 millimeters can be achieved by this technique. However, this technique has the disadvantages in that it is time consuming and requires the cooperation of the patient and the parents. The external fixation frame is often in place for upward of 4 months to achieve consolidation of the skeleton. In this period, pin loosening and pin site infections can complicate the process, and skeletal lengthening may exceed the capacity of the soft tissue envelope and produce tender bony prominence of the fingertip. The second technique of lengthening of the shortened bone in brachydactyly is single stage lengthening, which consists of 4 steps. This type of lengthening is preferred when brachydactyly is combined with angulation because both can be corrected by this technique. The first step in this procedure is the cutting of the bone, which can be done in the form of a step cut osteotomy, chevron osteotomy, or a double shaped osteotomy, which is nothing but coring out bone in the form of a cylinder. After the bone is cut, the second step of soft tissue release, reconstruction of the transverse metacarpal ligaments, and advancement of the origins of the interosseous muscles needs to be done. This can be done by the Tajima technique, where the entire dorsal interosseous muscle and the volar interosseous muscles are released from one side of the involved bone, or the Buck-Gramco technique, where the incision to release the muscles is done on both sides. The third step consists of using an intercalary bone graft in the gap that has been formed by advancing the osteotomized bone, and the final step consists of fixation, which could be done either by external fixation, K-wires, or internal fixation with plate and screws. Apart from bone lengthening procedures, there are other options available for the management of brachydactyly. Bone transplantation using toe phalanx can be done, but this must be done before 2 years of age of the child to avoid resorption of the transplanted bone segments. The middle phalanx from the second to the fifth toes can be used. This non-vascularized bone graft is placed into a skin pocket developed in the finger, and the transplanted bone is stabilized with closure of any available surrounding tendons and soft tissues. Instead of harvesting the toe phalanx as a free graft, part of the distal metatarsal with a part of the epiphysis could be fashioned and used as a graft. This matchstick type of graft could be more easily tailored to need. It carries a physis, and the donor defect can heal itself without any residual problems. It has the potential to grow and lengthen with growth of the hand. Transferring vascularized toe can also be done if the fingers are totally absent. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about other congenital differences in the hand like syndactyly and clinodactyly, and do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery and ethics.